Assalamu alaikum and hello everyone. I am Dr. Samana, one of the mentor at Study FCPS. Here we are starting P series, which will helpful in your upcoming exam. We will cover the most important topics which are exam related. So please like and subscribe to our YouTube channel that you are more updated with that. Today I am discussing with the core surgical skills and the perineal tears, which are very important for the exam. The sutures are classified into absorbable and non-absorbable suture. Among the absorbable suture are the synthetic, which are monocryl, vicryl, PDS, and the natural, which are collagens. And the non-absorbable suture are synthetic, which are ethylone and proline, and the natural are the surgical cotton, surgical silk, and surgical steel. What is the incidence of perineal tear? These are very important. The overall incidence is 2.9%. In primipara, it is 6.1%. In multipara, it is 1.7%. And the recurrence is 5 to 7%. Residual anal sphincter defect after repair is 19 to 36%. And the 60 to 80% are asymptomatic after repair after the 12 months. Now, what are the risk factors? There are Asian ethnicity, nulliparity, birth weight greater than 4 kg, shoulder dystocia, occipito-posterior position, prolonged second stage of labor, and instrumental delivery. These are the perineal tears. These are classified from 1st degree to 4th degree. In 1st degree, here there is a breach in the vaginal mucosa. In the 2nd degree, along with this vaginal mucosa, the muscles are involved. These are mainly the bulbocavernous muscle and superficial transverse perineal muscles. And in the 3rd degree, the sphincters are involved. These are further categorized into 3A, 3B, and 3C. And in the 4th degree, along with this sphincters, the rectal mucosa is involved. Let's do some detailed description. In 1st degree, a shallow injury that affects the skin only of the vaginal mucosa or perineum. It may heal on its own or require stitches, and the recovery is usually within the first few weeks or months after birth. In the 2nd degree, an injury that affects the perineal muscles usually requires stitches, and recovery is usually within the first few weeks or months after birth. In the 3rd degree, an injury that affects the perineal muscles and anal sphincter muscles. And there are 3 subclassifications, usually requires stitches given in an operating theater under anesthesia. And 3A, it is less than 50% of the external anal sphincters injured. 3B, when the more than 50% of the external anal sphincter is injured, and 3C, when both the external and internal anal sphincters are injured. In the 4th degree, an injury to the perineum that extends through the anal sphincter to the anal epithelium. It usually requires stitches given in an operating theater under anesthesia. Now, what is the rectal buttonhole tear? Sometimes when there is tear involve the rectal mucosa with an intact anal sphincter complex. It is by definition not a 4th degree tear. It has to be documented as a separate rectal buttonhole tear. If it is not recognized and repaired, this type of tear may lead to rectovaginal fistula. Now, what are the prediction and prevention of obstetric anal sphincter injury? The prediction is by the clinicians need to be aware of the risk factors for obstetric anal sphincter injury. Clinicians should be aware, however, that risk factors do not allow the accurate prediction of the obstetric anal sphincter injury. How we prevent the obstetric anal sphincter injury? Clinician should be explained that the evidence of protective effect of episiotomy is conflicting. The mediolateral episiotomy should be considered in instrumental delivery. Angle is 60 degrees away from the midline, and perineal protection at crowning is protective. Warm compression during the 2nd stage of labor reduce the risk of obstetric anal sphincter injury. Now, identification of the obstetric anal sphincter injury. It is very much important. All women having vaginal delivery are at risk of sustaining obstetric anal sphincter injury should be examined systemically, including the digital rectal examination to assess the damage prior to suturing. And the woman should be in the lithotomy position to allow adequate visual access and the degree of trauma. In case of uncertainty, the woman should be referred to the more experienced healthcare professional. So the recognition and the repair is very much necessary. Now, how we repair the obstetric anal sphincter injury? The repair of 3rd and 4th-degree tears should be conducted by an appropriately trained clinician or by the trainee under supervision. Repair should take place in the operating theater under regional anesthesia or general anesthesia with a good lighting and with appropriate instruments. A rectal examination should be performed after the repair to ensure that the suture have not been inadvertently inserted through the anorectal mucosa. If the suture identified should be removed. So examination of the repair is very much necessary. Now, how we repair the obstetric anal sphincter injury. When there is anorectal mucosa is affected, we will repair by the continuous or the interrupted sutures with 3,0-polygalactin. Internal anal sphincter is repaired by the end-to-end with 3,0-polygalactin PDS or 2,0-polygalactin. External anal sphincter, full thickness, it will be repaired by end-to-end or overlapping. It depends upon surgeon's ability. It is by the 3,0-PDS or 2,0-polygalactin. And external anal sphincter, partial thickness should be repaired by end-to-end by the 3,0-PDS or 2,0-polygalactin. Now the post-operative care, it is very much important. Broad-spectrum antibiotics are recommended to prevent the infections, and post-operative laxatives is recommended. Bulking agent should not be given routinely with laxatives. Physiotherapy following repair of obstetric anal sphincter injury should be beneficial. If the woman is experiencing incontinence or pain, referral to a specialist gynecologist or colorectal surgeon should be considered. Women who have undergone obstetric anal sphincter repair should be reviewed at a convenient time, usually 6 to 12 weeks postpartum, where the possible review should be by clinician with a specialist interest in the obstetric anal sphincter injury. So this is post-operative care. Now, what is the prognosis? Women should be advised that 60 to 80% of the women are asymptomatic 12 months following delivery. What is the future delivery? All women who sustain obstetric anal sphincter injury in a previous pregnancy should be counseled about a mode of delivery, and this should be clearly documented in notes. The role of prophylactic episiotomy in subsequent pregnancy is not known. Episiotomy should only be performed if clinically indicated. All women who sustain obstetric anal sphincter injury in a previous pregnancy who are symptomatic or have the abnormal endoanal ultrasound or manometry should be counseled regarding the option of elective cesarean birth. And if the woman is asymptomatic, there is no any abnormality in the endoanal ultrasound and manometry, she can go for the vaginal delivery. What are the risk management? Units should have the clear protocol for the management of obstetric anal sphincter injury, documentation of the anatomical structure involved, the method of the repair, the suture material should be met. The woman should be fully informed about the nature of the repair and tear, and the offer a follow-up should be made, all supported by relevant written information. So we should debrief the woman and documentation should be done post-operatively. Now let's do some SBAs. Question number 1. A 30-year-old woman who has just had a normal vaginal delivery at term sustained a perineal tear that involves the 50% of the external anal sphincter and you are called to see this tear. How will you classify the degree of tear? A, second degree, B, 3A degree, C, 3B degree, and D, 3C degree. E is a fourth degree. Now let's see the answer. It is B, 3A degree. Let's check why other options are wrong. Because when there is more than 50%, it is 3B, and when it is 50%, it is 3A. And vaginal muscles are involved with no any involvement of the anal sphincter, it is second degree. And when the internal anal sphincter is involved, then it is 3C. And when the rectal mucosa is involved, that is 4 degree. So it is 3A degree. The current classification of perineal trauma includes the classification of the anal sphincter tears. The first degree involves the laceration of the vaginal epithelium. Second degree involves the primary muscle but not the anal sphincter. Third degree involves the disruption of the anal sphincter. And 3A, less than 50% of the external anal sphincter involved. 3B, more than 50% of the external anal sphincter is involved. And 3C, both external and internal sphincter are involved. And 4 degree, the rectal mucosa is involved. I hope it is clear. Let's move on for the next question. What is the most appropriate suture material to repair the anorectal mucosa in 4 degree perineal tear? It is A, PDS, B, polygalactic vicryl rapid, and C, polygalactane vicryl, and D, polyglycopyrrone monocryl, and the E is polyglycolic acid dexone. Let's see the answer. It is C, 30 polygalactane. Why we choose this stitch? 30 polygalactane should be used to repair the anorectal mucosa. It may cause less irritation and discomfort than polydexone suture. When repair of the external and internal anal sphincter muscle is performed, either monofilament suture such as 30 PDS or modern braided suture such as 20 polygalactane can be used with equivalent outcome. So that's why we use 30 polygalactane for the anal mucosa because it is less irritation and less discomfort. Let's move on the next question. A 32-year-old woman had a forceps delivery due to maternal exhaustion. All her observations are normal and placenta delivery complete. Perineal examination revealed a torn external anal sphincter to about 80%, and she was counseled and taken to the theater for the repair. What technique should be repair external anal sphincter? A, end-to-end using 30 PDS, B, end-to-end method using 20 PDS, and C, end-to-end method using 30 vicryl, and the D, overlapping method using 20 vicryl, and E, overlapping method using 30 vicryl PDS. Let's check the answer. It is A, end-to-end method using 30 PDS. For repair of the full thickness external anal sphincter tear, either an overlap technique or end-to-end approximation method can be used with equivalent outcomes. And for partial thickness tear, use end-to-end technique. For anal sphincter injury, either monofilament suture such as 30 PDS or modern braided suture such as 20 polygalactane can be used. So we choose end-to-end method by the 30 PDS. Next question is a 25-year-old woman delivered by vacuum delivery for fetal distress. On examination was found to have a buttonhole rectal mucosa tear. The most appropriate repair would be, it is A, the continuous suturing with 30 polygalactane with half circle needle, B, end-to-end interrupted sutures, C, figure of 8 suturing with polygalactane, and D, overlapping technique, and E, tapered cut semicircular needle. Let's see the answer. It is A, continuous suturing with 30 polygalactane half circle needle. Rectal buttonhole tear, as I already discussed, it is a tear involves the rectal mucosa with an intact anal sphincter complex. And it by definition, it's not a fourth degree tear. It is a separate. So whenever we encounter the rectal buttonhole tear, we will document it as a separate. If not recognized or repaired, this type of tear may lead to rectovaginal fistula. So we repair it by continuous or interrupted suture techniques. But the mattress suture should be, figure of 8 sutures should be avoided because it can cause the tissue ischemia. This is the last question. A woman in the theater for the repair of 3C tear, and she has given spinal anesthesia and antibiotics. Which suturing technique is most suited for the torn internal anal sphincter? Number A, continuous lock 30 PDS, B, continuous unlock 30 PDS, and C, end-to-end technique, D, figure of 8 suture, and E, overlap technique. Let's see the answer. It is C, end-to-end technique with the interrupted suture. When the torn internal anal sphincter identified, it is advisable to repair this separately with interrupted or mattress suture with a attempt to overlap the internal anal sphincter. We cannot use here the figure of 8 suture because it is causing the tissue ischemia. That's all about my topic. Hope and you much enjoying and wish you all the best for the exam. And if you are not subscribing, you can subscribe to our YouTube channel that you are more updated to our recent new Triple P series. Thank you very much.